Welcome to the deep dive. Today we are digging into a complex stack of source material focused entirely on the pathophysiology of the female reproductive system.
Exactly. This deep dive is really designed to be your shortcut through a lot of dense info.
Yeah, connecting the why of the disorder directly to the symptoms you see clinically.
Right. And this material, it takes us structure by structure, from the external genitalia all the way up to the ovaries.
Covering inflammation, hormonal chaos, benign conditions, critical malignancies, the whole gamut.
And the common thread, I think, running through almost all of these, whether it's an acute infection or chronic cancer, is how subtle, sometimes vague symptoms are often those first warning signs.
That's really our mission here. Synthesize the pathogenesis, the clinical signs, the diagnosis for you. So you walk away understanding the mechanics, the hormones, the cells behind it all.
Okay, so let's get started. Where should we begin?
Let's start right at the surface. Disorders of the external genitalia and the vagina.
Okay. A really common one, especially acute, is the Bartholin gland cyst. The basic problem is pretty straightforward. The duct of the gland, it secretes lubricating fluid, it gets blocked. Occluded.
Creating a fluid-filled sac. Simple enough, but what happens if bacteria get in there?
Then it becomes an abscess. Often things like staph, chlamydia, anaerobes, they can all cause it.
And clinically, what are we looking for? What is the patient experience?
Well, the acute symptoms are pretty distinct. Severe localized pain, definite swelling, and dyspareunia.
Which is the medical term for painful intercourse.
Exactly. And one key point, these glands tend to atrophy, shrink after menopause. So if an older patient presents with a new growth there,
Red flag.
big red flag, you've got to rule out malignancy, full evaluation needed.
Okay. And for a simple infected cyst, the treatment?
Usually involves antibiotics, of course, and then an incision and drainage, or IND. Often they'll place a little word catheter, a small drain, to make sure it stays open and drains completely.
Got it. Okay. Stepping back from acute infections for a second, what about those non-neoplastic epithelial disorders, the ones that can sometimes be precursors to cancer?
Right. The sources mention a few, like lichen simplex chronicus, lichen planus. But the one to really focus on is lichen sclerosus.
Why that one specifically?
Well, what's crucial about lichen sclerosus is that it's an inflammatory condition. It leads to vulvar atrophy, thinning, sometimes contracture.
Gives the skin that sort of parchment-thin look?
Exactly. And the really high-leverage insight here is that this chronic inflammation significantly bumps up the risk for progression to vulvar malignancy later on.
Okay. Then there's vulvodynia. This chronic vulvar pain lasts at least 3 months, right? And it's notoriously tricky to diagnose, often a diagnosis of exclusion.
That's right. And we tend to classify it based on how it presents. There's the localized type, or vestibulodynia.
That's the stinging, cutting pain, usually provoked by touch or pressure, like intercourse or even tampon insertion.
Precisely. The thinking there is it might involve sensitized local pain circuits, almost like the nerves are on high alert.
Contrasted with the generalized type.
Yeah, generalized vulvodynia is, well, much more severe. It's often a constant widespread pain, often unprovoked. It shares features with neuropathic pain disorders like, say, pudendal neuralgia.
Okay, that nerve sensitization idea is a good bridge. If the external structures rely on that delicate pH balance, what happens when it fails?
Yeah.
That gets us to vaginitis.
Right. Normal vaginal health hinges on its ecology, specifically the dominance of lactobacillus bacteria.
They keep things acidic, right? pH is around 4.0 to 4.5.
Exactly. But when that balance gets disrupted, maybe antibiotics wiped out the good bacteria, or douching, or big hormonal shifts, women become much more susceptible to infection.
So if hormonal change is the trigger, what's a really common scenario? Maybe postmenopausal women.
That would be atrophic vaginitis. Estrogen levels drop, so the vaginal secretions become less acidic, the tissues thin out.
Making them easily irritated.
Highly susceptible, yeah.
Yeah.
Clinically, that shows up as itching, burning, and painful intercourse. Now, diagnostically, this is important. A saline wet mount smear under the microscope is great for identifying most organisms, like bacteria or trichomonas. But remember,
You need something else for yeast.
you absolutely need the potassium hydroxide prep, the KOH prep. The KOH dissolves the other cells, making it much easier to see the characteristic hyphae and budding yeast of candidiasis. Can't reliably diagnose yeast without it.
Good clinical pearl. Okay, let's move inward now to the cervix. Such a critical site, especially for cancer development. We have to talk about the transformation zone.
Yes, this is fundamental. The cervix has two main cell types covering it. Stratified squamous cells on the outside, the part you see in the vagina, that's the exocervix.
And then columnar epithelium lining the canal leading up to the uterus, the endocervix.
Right, and the transformation zone is simply where these two types meet. But it's not static. During the reproductive years, the cervix kind of everts, turns outward slightly.
And those columnar cells get exposed to the vaginal environment.
And they change. They transform into squamous cells. That process is called metaplasia.
And it's this area of constant cellular change, influenced by hormones, maybe infections like HPV. That's what makes it vulnerable to dysplasia, to abnormal changes.
Precisely. That vulnerability is why cervical cancer is so tightly linked to sexually transmitted HPV, particularly those high-risk types, 16 and 18.
Okay, so the progression is usually pretty orderly, right? It starts with atypical cells.
Then progresses through cervical intraepithelial neoplasia, or CIN. We grade it CIN II or III based on how much of the epithelial thickness shows abnormal cells.
And how does that relate to the Pap smear results, like LGSIL and HGSIL?
Good question. LGSIL, or low-grade squamous intraepithelial lesion on a Pap, typically corresponds to CINI on a biopsy milder changes. HGSIL high-grade is much more concerning. That usually correlates to CIN II or CIN III, the more significant high-risk changes that really need intervention.
And the big success story here is early detection. The Pap smear has been incredibly effective.
Absolutely. And now often combined with HPV co-testing, especially for women over 30, and the treatment has also gotten much better, much less invasive.
Right, we don't do as many cone biopsies anymore.
Not as first line for CIN III generally. The LEEP loop electrosurgical excision procedure is now preferred. It uses a thin electrified wire loop to shave off the abnormal area.
Removes the lesion, but preserves more of the cervix.
Exactly. Much better for future fertility. But ultimately, the big strategy is preventionator. The HPV vaccine targets the main cancer-causing strains.
Okay, let's pivot now to the uterus itself and discuss endometriosis. This is functional endometrial tissue, the uterine lining, but found in ectopic sites outside the uterus, and it's estrogen-dependent.
That's the definition. The leading theory for how it gets there is Sampson's theory of regurgitation or retrograde menstruation.
Meaning menstrual blood, containing viable endometrial cells, flows backward through the fallopian tubes and implants in the pelvic cavity.
That's the idea. And because this tissue is functional, it responds to hormones. It proliferates and bleeds cyclically, just like the uterine lining.
But it's bleeding inside the pelvis, where it shouldn't be.
Right. And that causes chronic inflammation, pain, scarring, adhesions, tying organs together.
Which explains the classic symptoms: pelvic pain, especially worsening before the period, painful intercourse, and often infertility.
Exactly. And when these implants occur on the ovaries, they can form cysts filled with old, broken-down blood. They have a very specific look.
Endometriomas, often called chocolate cysts because of that thick, dark brown fluid.
That's the one. Diagnosis usually requires actually looking inside with a laparoscope. Treatment focuses on managing pain and suppressing that estrogen stimulation.
So things like NSAIDs, combined birth control pills.
Yes, or more potent options like GnRH analogs. These drugs basically shut down ovarian hormone production, inducing a temporary reversible menopause to stop the tissue from cycling and bleeding. Surgery to remove implants is also an option.
Now, you mentioned connecting this to the bigger picture. A good condition to contrast with endometriosis is adenomyosis.
Right. It's often confused, but it's distinct. Adenomyosis is also endometrial tissue glands and stroma, but instead of being outside the uterus, it's found within the myometrium.
Embedded deep in the muscular wall of the uterus itself.
Exactly. And the clinical picture is different too. Adenomyosis tends to affect women who've had children, maybe a bit older. It causes very heavy, painful periods, and the uterus feels enlarged, soft, kind of boggy on exam, unlike the distinct lumps of fibroids.
And because it's diffuse within the muscle.
Conservative medical treatments often don't work as well as they might for endometriosis. Hysterectomy is frequently the definitive treatment for severe symptoms.
Okay, now shifting to malignancies of the uterus, the most common female pelvic cancer. Endometrial cancer occurs more than twice as often as cervical cancer, right?
That's correct. And the pathogenesis, especially for the most common type, type 1, is really important to grasp.
It's all about estrogen.
Primarily, yes. Prolonged, unopposed estrogen stimulation. Meaning situations where estrogen levels are high, causing the endometrium to build up, but there isn't enough progesterone to trigger regular shedding.
Like in obesity, where fat cells make estrogen, or anovulatory cycles where no progesterone is produced, or certain hormone therapies without added progesterone.
Exactly. All those things lead to endometrial hyperplasia and overgrowth, which can then progress to malignancy.
And the clinical takeaway here is absolutely critical. The major symptom is
Abnormal bleeding, often painless. And the mantra has to be, any bleeding in a postmenopausal woman is abnormal until proven otherwise.
needs immediate investigation, usually an endometrial biopsy.
Absolutely, because the prognosis is generally very good if caught early.
Okay, moving up to the fallopian tubes and ovaries. This is where we can get into some real emergencies. Let's start with pelvic inflammatory disease, PID.
Right. PID is a polymicrobial infection spreading up into the upper genital tract, the uterus, the tubes, the ovaries.
Usually starting from sexually transmitted infections ascending from the cervix, like gonorrhea or chlamydia.
Those are the most common culprits, yes. The bacteria travel up through the endocervical canal. This is thought to be easier during menstruation when the cervical mucus plug is less protective and the canal might be slightly dilated.
Okay. Clinically, what's the presentation? Lower abdominal pain, discharge.
Yes, but the hallmark findings on pelvic exam are what really clinch it. You'll find adnexal tenderness pain when palpating the area of the ovaries and tubes, and classically, cervical motion tenderness.
Sometimes called the chandelier sign.
Exactly, because even slight movement of the cervix during the exam causes such intense pain, the patient might figuratively jump for the chandelier. It indicates significant peritoneal inflammation.
And the long-term consequences of PID are serious.
Very serious. Scarring within the tubes, pelvic adhesions, chronic pelvic pain, infertility, and critically, a significantly increased risk of ectopic pregnancy.
Which is our next topic, a true gynecologic emergency. The fertilized egg implants outside the uterus.
Most commonly, about 95% of the time, it's in the fallopian tube.
Risk factors track back to things that damage the tube, right? Like previous PID, tubal surgery.
Correct. Also things like fertility drug use that might affect tubal motility.
And the clinical clues for a potential ectopic, especially if it's rupturing, what do we need to look for?
Severe abdominal pain, often localized to one side initially, vaginal spotting or bleeding, sometimes dizziness or fainting, syncope due to blood loss, and that classic sign.
Referred shoulder pain.
Yes, caused by blood accumulating under the diaphragm, irritating the phrenic nerve. If you see that, think intra-abdominal bleeding. It's an emergency.
Treatment has evolved, though. It's not always surgery now.
Not always. For early, unruptured ectopic pregnancies, medical management with methotrexate is often possible. It stops the cells from dividing. But if there's rupture or instability, surgery, usually laparoscopy, is absolutely necessary.
Okay. Turning to the ovaries themselves. Beyond simple functional cysts, which are common and usually resolve on their own.
Right, follicular cysts, luteal cysts, they generally regress, only problematic if they twist or rupture.
But then there's Polycystic Ovary Syndrome, or PCOS. Hugely common, affects so many reproductive age women. What are the key diagnostic criteria?
You generally need 2 out of 3. First, oligo or anovulation, meaning infrequent or absent ovulation leading to irregular periods. Second, clinical or biochemical signs of hyperandrogenism, excess male hormones.
Like hirsutism, acne, maybe elevated testosterone levels.
Exactly. And third, polycystic ovaries seen on ultrasound, though this isn't strictly required if the other 2 are present.
Now, the single biggest takeaway on PCOS, it's not really about the cysts themselves, is it?
Not fundamentally, no. The cysts are more a symptom. The core issue, the engine driving the whole thing, seems to be insulin resistance and the resulting hyperinsulinemia.
So the body isn't using insulin effectively, the pancreas pumps out more, and that high insulin level acts on the ovaries.
Precisely. Excess insulin stimulates the ovaries to produce excess androgens. That drives the hirsutism and acne. It also disrupts the normal feedback loop with the pituitary, altering the LH-FSH ratio, which prevents normal follicle development and ovulation.
So it's really a metabolic disorder presenting as an ovarian or reproductive problem.
That's a great way to put it. Management often involves addressing the insulin resistance alongside managing the periods and hyperandrogenism.
Okay. And finally, for the ovaries, ovarian cancer, still one of the most lethal female cancers. Why is that?
Primarily because the symptoms are so vague and nonspecific, especially early on. Bloating, feeling full quickly, early satiety, maybe some abdominal or pelvic discomfort, changes in bowel habits.
Things easily dismissed as minor GI issues.
Exactly, which means diagnosis is often delayed until the cancer has already spread beyond the ovary, making it much harder to treat successfully.
Risk factors. We know genetics play a role, BRCA1 and 2.
Yes, significant genetic component. Also, factors related to ovulatory age. Essentially, the more times a woman ovulates in her lifetime, the higher the risk seems to be. Things that suppress ovulation, like pregnancy or long-term oral contraceptive use, appear protective.
And the diagnostic challenge. There's no effective screening test like the pap smear for cervical cancer, right? What about CA-125?
Right. No universal screening tool exists. CA-125 is a tumor marker that can be elevated in ovarian cancer, but it's not specific enough for screening asymptomatic women. It can be raised by many other benign conditions like endometriosis or even menstruation. It is useful, however, for monitoring treatment response or recurrence in women already diagnosed. Definitive diagnosis and staging always require surgery.
Okay, let's transition now. Thinking about the consequences of pelvic floor weakness, often related to childbirth, aging, the disorders of pelvic support.
Yeah, the pelvic floor muscles and ligaments act like a hammock, supporting the bladder, uterus, and rectum against gravity and intra-abdominal pressure, coughing, sneezing, lifting.
When that support weakens, things start to bulge or herniate into the vagina.
Exactly. Leading to prolapse, there are several types depending on what's herniating.
Like cystocele.
Right. That's when the bladder bulges into the anterior vaginal wall. Symptoms often include difficulty emptying the bladder completely, maybe stress incontinence, leaking urine with coughing or sneezing.
And rectocele.
That's the rectum bulging into the posterior vaginal wall. This causes difficulty with defecation. Patients might report needing to push on the back wall of the vagina what we call digital pressure or splinting just to have a bowel movement.
And then the uterus itself can descend. Uterine prolapse.
Yes, it's graded based on severity. From mild descent down into the vagina all the way to procedentia, where the entire cervix and uterus protrude outside the body.
Treatment options.
Depends on severity and patient preference. Can range from non-surgical approaches like Kegel exercises to strengthen the pelvic floor, or using a pessary, a supportive device inserted into the vagina, or surgical repair like colporrhaphy, which tightens the vaginal walls, sometimes combined with hysterectomy if prolapse is severe.
Okay. We also need to touch on abnormal uterine bleeding, or AUB. There's a newer classification system now, right? Instead of older terms like DUB.
Yes, the FIGO system uses the mnemonic PALM-COEIN. It's much better because it categorizes the causes of AUB systematically.
PALM covers the structural causes. P for polyps, A for adenomyosis, L for leiomyomas, fibroids, M for malignancy hyperplasia.
Exactly. And COEIN covers the non-structural causes. C for coagulopathy, bleeding disorders, O for ovulatory dysfunction, E for endometrial causes like local inflammation, I for iatrogenic caused by medications or devices, and N for not yet classified.
It forces a more thorough workup. What about the hormonal pathogenesis behind AUB, especially with ovulatory dysfunction?
That's key. If ovulation doesn't occur, an ovulation, there's no corpus luteum formed, so no progesterone is produced. You get continuous estrogen stimulation building up the endometrium without the stabilizing effect of progesterone.
So the lining gets thick, unstable.
And eventually breaks down and bleeds irregularly and often heavily. Characteristically, this type of bleeding is often painless or crampless because there aren't the prostaglandin-driven contractions associated with ovulatory cycles, common in adolescents and perimenopausal women.
Got it. And related to cycles, dysmenorrhea, painful menstruation. Primary versus secondary.
Right. Primary dysmenorrhea is just painful periods without any underlying pelvic disease, thought to be due to excess prostaglandins causing uterine contractions, usually treated effectively with NSAIDs or hormonal contraception.
Secondary dysmenorrhea means there is an underlying cause.
Exactly. Things like endometriosis, adenomyosis, fibroids, PID. The pain is caused by the specific condition. Treatment targets the underlying problem.
And then there's the spectrum of premenstrual symptom disorders, PMS, and the more severe PMDD.
Right. PMS involves a cluster of physical and emotional symptoms occurring in the luteal phase, resolving with menstruation. PMDD, premenstrual dysphoric disorder, is the severe disabling end of that spectrum, considered a psychiatric diagnosis in the DSM-5. Causes significant disruption in life.
The etiology isn't perfectly clear, but it seems related to sensitivity to normal hormone fluctuations.
That's the leading theory. Not necessarily abnormal hormone levels, but an abnormal response in the brain, possibly involving neurotransmitters like serotonin.
Which explains why SSRIs, the antidepressants that target serotonin, are often first-line treatment for severe PMDD.
Exactly. They can be very effective, sometimes even when taken just during the luteal phase.
Okay, let's wrap up with breast health and a quick overview of infertility. starting with benign breast disorders. Two key ones to differentiate.
Yes. First, fibroadenoma, classically described as a firm, smooth, rubbery, sharply defined mass. And crucially, it's highly mobile.
It kind of slides away under your fingers during exam.
Precisely. Feels like a marble.
Huh?
Importantly, it's not considered precancerous.
Okay. Contrast that with fibrocystic changes.
Fibrocystic changes are incredibly common, maybe the most frequent benign lesion, especially in women aged 20-50. They feel different, more nodular, granular, maybe lumpy or ropey texture, often bilateral.
And they tend to fluctuate with the menstrual cycle, more prominent and tender before the period.
Yes, typically most symptomatic during the luteal phase when progesterone is high. The key point here is that most forms of fibrocystic change, especially the non-proliferative types, do not significantly increase breast cancer risk. Proliferative changes with atypia do carry some increased risk, though.
All right, turn to breast cancer. The most common female cancer overall, excluding skin cancer. Risk factors.
Major ones include increasing age, female sex obviously, and genetic mutations, particularly BRCA1 and BRCA2. Then there are hormonal factors.
Things that increase lifetime estrogen exposure, like starting periods early menarche, late menopause, having a first child late or not at all.
Exactly. Also, obesity, especially postmenopausally, alcohol use, and previous radiation exposure.
Detection relies heavily on screening, right? Mammography and clinical breast exams.
Yes. Finding a lump is the most common sign, but also look for subtle changes like skin dimpling, nipple retraction, or changes in breast contour. Any suspicious finding needs investigation.
And diagnosis is always confirmed by
Biopsy. That's definitive. Once diagnosed, staging is crucial. This often involves Sentinel Lymph Node, SLN biopsy, where they identify and remove just the first few lymph nodes the cancer would likely drain to, rather than removing all axillary nodes up front.
minimizes lymphedema risk, and treatment is multimodal.
Very much so. Surgery, lumpectomy or mastectomy, radiation, chemotherapy, and hormonal manipulation is key for many.
Like tamoxifen for estrogen receptor, ER-positive tumors in premenopausal women.
Right. It blocks estrogen's effect on the cancer cells. And for postmenopausal women with ER-positive cancer, aromatase inhibitors, AIs, are often used. They block the production of estrogen in peripheral tissues, which is the main source after menopause.
Okay. Finally, a brief look at infertility, defined as inability to conceive after 1 year of regular, unprotected intercourse, or 6 months if the woman is over 35.
That's the general definition, yes. Causes are roughly split between female factors, male factors, and unexplained.
Female factors are complex. It could be issues with the eggs.
Right. Oocyte quality and quantity, what we call diminished ovarian reserve, DOR. We assess this using hormone levels like FSH, estradiol, and especially AMH, anti-Mullerian hormone, which gives a sense of the remaining egg pool.
Could also be problems with ovulation itself.
Absolutely. Ovulatory dysfunction, like in PCOS. We check for this using basal body temperature charting, ovulation predictor kits, testing for the LH surge, or progesterone levels.
Then there are issues with the cervix, uterus, or tubes.
Yes. Cervical mucus problems affecting sperm transport. Uterine cavity abnormalities like fibroids or polyps interfering with implantation. And critically, tubal factors are the tubes open, patent, and mobile. Scarring from previous PID is a major cause of tubal infertility.
And we can't forget male factors.
No, accounts for maybe 30–40% of cases. Assessed via semen analysis, looking at sperm count, density, motility, movement, and morphology shape.
When natural conception isn't happening or isn't possible, that's where assisted reproductive technology, RT, comes in.
Primarily IVF, in vitro fertilization. Eggs are retrieved, fertilized with sperm in the lab, and the resulting embryos are transferred back into the uterus.
Bypasses many of the issues like tubal blockage or sperm problems.
Correct. Though success rates depend heavily on factors like female age and egg quality. Donor eggs or sperm are also options, particularly for women over 40 or those with severe male factor infertility.
So wrapping this all up, we've covered a huge amount of ground. Acute infections like PID, emergencies like ectopic pregnancy, chronic hormonal disorders like PCOS and endometriosis, major cancers.
Yeah, it's a lot, but I think if you step back, a major theme is just how interconnected everything is. The hormones, the anatomy, the immune response, and maybe how crucial early detection and risk factor awareness are.
That's absolutely the takeaway. Think about CIN screening preventing cervical cancer. Recognizing that postmenopausal bleeding needs immediate investigation for endometrial cancer, or even just being aware that those vague GI symptoms could be ovarian cancer. Early intervention changes everything.
It really does. And it raises, I think, an interesting question for you, the listener, to consider going forward.
Okay.
We've seen how many of these chronic reproductive issues, type 1 endometrial cancer, PCOS, maybe even aspects of endometriosis, are fundamentally driven or exacerbated by unopposed estrogen states, often linked to metabolic factors like insulin resistance. So the question is, how might a deeper, more integrated understanding of metabolism, particularly insulin sensitivity, fundamentally change how we approach preventative strategies for women's reproductive health in the future, beyond just managing symptoms?
That's an excellent challenge. Moving beyond just the reproductive organs and looking at the whole endocrine and metabolic picture as potential leverage points. Great food for thought. Thank you for joining us for this deep dive into the pathophysiology of the female reproductive system. We hope this helps make these complex topics a bit clearer.